Good afternoon, my friends. As you heard already, two very important papers, and you'll hear more about. And there are so many forgotten wisdoms and so many influential trials that it's really impossible for somebody who lives already 74 years like me to choose one. So I will be very selfish. I will go to what did something to me, rather than choosing something for the rest of the humanity. Next. So I will tell you a story that I call a tale of an unimportant publication and individuals caught in trends. Next. And of course, this will be my own perspective, my own experience, my own issue about one paper. And instead of unforgotten wisdom, next, I will talk to you about unforgotten wisdom. And the first point I want to make is that the study that may be considered forgettable by most may be a life game changer for some. And this is the example. Next. So the story starts about 48 years ago, where all of a sudden with the improvement of blood cultures, people started to understand that children can be looking not that sick, but can go into walk-in clinics and get pneumococcus or Haemophilus or meningococcus in the blood. And within 3 years, it became very popular to look for it. And it was termed walk-in bacteremia or occult bacteremia. And people started to say, oh my God, what we are missing if we don't do that. And again, in no time, it was very, very clear that you are not allowed to miss those cases, especially if they are very, very young, under the age of 3 months, because they can have serious bacterial infections. And therefore, it has a very important significance if you miss some of those. Next one. And so to be on the safe side for all these children, not to miss any, within no time, it became sort of the very important rule. It started in the States and then started to go from there everywhere. Every febrile infant under the age of 2 to 3 months of age, you have to put him under rule-out sepsis workup, which means hospitalization, blood culture, CSF examination, urine culture, and put the child onto IV antibiotics, wide spectrum for at least 48 hours. And this started to become a global trend. Next, so much that when very known people like Sarah Long started to write approach and guidelines, they use the words which are almost like, almost like the Bible. All patients should be admitted to the hospital. Performance of laboratory tests in outpatient is inappropriate. Performance of blood culture in outpatient is inappropriate. Next. So very clear that in no time, standards of care managing febrile infants younger than 2 to 3 months of age in early 80s left no room for option. The left picture, which is a nice smiling guy with a little bit of fever who is 2 months old, is passé, it's outdated. What is trendy now is to take that child, put that child in the hospital and see this type of pictures and imagine what happens if you're the mother or the father and see that picture in your child just because of a little bit of fever. And it was all to be on the safe side for the sake of the child. And I was resident at that time, and then I was young fellow, and I was following this trend very enthusiastically because I wanted to save all children, like all young people. Next. But then one day, in 1983, there's a paper in a second-line journal. And that paper was a small paper, was written by a pediatrician from Johns Hopkins, Cathy De Angelis, who eventually, later on, became the editor of JAMA for many years. But at that time, she was a pediatrician in Johns Hopkins. And she called that paper Iatrogenic Risks and Financial Costs of Hospitalizing Febrile Infants. This was 8 years after the whole trend began. And she was posing the question if it's really safe. But she was very gentle in her words, but not in the facts she presented. Next. In fact, this was so shocking. Look at this. So these are the facts that she presented. 109 71 febrile infants with 927 admissions under 16 days of age, hospitalized in the Johns Hopkins Medical Center for rule-out sepsis workup because they were febrile and they did not have an apparent focus. Okay, not very sick children. 20%, look at the yellow background there. 20%, 1 out of 5 of these children had something bad occurring to that child in the hospital during this workup. 1 of 5. And some of those things were very, very serious. Look at this in the red squares. 1 distraught mother secondary to multiple lumbar punctures. Of course, multiple lumbar punctures, because lumbar punctures are done in these young kids by the first-year resident. They have to learn how to do lumbar punctures. So, of course, you don't do only 1. You do many until you get 1 successful. And then stolen infant who was never found. Just they lost their child because it was stolen. Chlorphenicol sodium succinate induced bone marrow suppression. That was the antibiotics that they used at that time for rule-out sepsis, wide spectrum. And then misadventure, look at traumatized infants, secondary to multiple lumbar punctures, 2 of those, and then 1 that was kept for 48 hours for neurological consultation that was never done, by the way. And then if you look, 87 of 89, 98% of the infants with no obvious bacterial illness and negative culture stayed in the hospital over 3 days just for nothing. And only 1 of all these may have had a potentially life-threatening illness that was missed on outpatient evaluation and maybe could have been treated if discovered later. So I looked at this and I could not believe my eyes. This is what I'm doing? Is this for the sake of the children? And I could not sleep for a whole week. I could not. And I said, I cannot do that anymore. So next slide. The next 6 years I spent to try to sort out children who do not have to go to the hospital just because they have fever. So the first 3 years in the paper on the left, identification of the infants unlikely to have serious bacterial infection, although hospitalized for suspected sepsis. And this I did in my fellowship in Rochester. And on the right, ambulatory care of febrile infants younger than 2 months of age, classified as being at low risk for having serious bacterial infection. So I made up some criteria that later were called the Rochester criteria because they were actually started. The first study was in Rochester, but actually they should have been called the Beersheba criteria because I thought about this already when I was in Beersheba and trying to get sorted out. And 2/3 of those children actually did not have to be in the hospital and could be prevented. Next. But this was not the best criteria. And until now, every year we have more and more paper coming out and more people trying to find criteria that will put these children out of the hospital because we understand it's not good for the child. It's not for the good for the child to be in the hospital. It's exactly the contrary. Next one. So that paper, that small paper that most of you have never read, and those who read it probably forgot, changed my life. That was reading this paper, which I made my decision. I'm going to dedicate all my career to prevention. Prevention. Next slide. The only direction is the prevention avenue. Next slide. And you can check it in my CV. All my life after that came for prevention of hospitalization, either by ambulatory management, shortening of hospitalizations or whatever. And then, of course, prevention by vaccine. And this is what I'm doing until now. So my point is very clear. I need to prevent children from seeing even the hospital. If I can prevent them from seeing a physician. Next. So the unforgotten wisdom for me is the study considered forgettable by most, may be a life game changer for some. There is no studies that are unimportant if they are done appropriately. And the second point, and you already saw me fighting for this 2 years ago in ESPID, never follow trends. Remember, your role is to protect your patient, not to follow your friends. Don't go by trends. try to read all the guidelines that are very trendy, very carefully, think about the patient, and be thankful to those who write paper for your use. Thank you.